Good morning, everybody. I'm happy to introduce Dennis Oswald. He's a fifth-year resident. He joined us last year, and he will talk about acute pancreatitis with a special focus on biliary pancreatitis.
Thank you very much for the introduction, and welcome, everybody. Today I'm going to talk about acute pancreatitis in general and some specialties in treatment of biliary pancreatitis. I'm going to talk about the epidemiology, etiology, diagnosis, classification, and the therapy of acute pancreatitis. The acute pancreatitis is a common gastrointestinal disorder. The worldwide incidence is rising the last few decades, and in Western Europe it's around 15 to 30 per 100,000 person years. There are more male than female patients, and the mortality rate has fallen steadily in the recent decades and is now around 2 to 5% of all pancreatitis. But, and that's a big but, it rises up to 30% in case of a severe pancreatitis. In the first 2 weeks, it's due to a systemic inflammatory response syndrome with multiple organ failure, and later on due to infectious complications. I'm going to talk about the different severity grades and type of pancreatitis later. I just want to show you this slide to show the heterogeneity of the course of a pancreatitis. If you have a mild pancreatitis, that's around 80% of the cases. There's mortality of only around 1%. But if you go on the left side, a severe pancreatitis, especially with infected necrosis, the mortality rises up over 30%. Now, to the etiology, I would like to ask one of the residents, what is the most common cause of acute pancreatitis?
Gallstones.
Exactly. The most common cause is a biliary. It's due to gallstones or sludge. And it's important to say that sludge can make the exact same problems as a concrete gallstone. Gallstones in the bladder are a very common disease and often asymptomatic. But if they migrate, they can lead to a transient or permanent obstruction of the pancreatic duct and trigger pancreatitis. And I would like to ask another resident, what is the second leading cause of a pancreatitis?
Alcoholic drinks.
Yes, perfect, Daniel. That's alcohol. It's up to 30% of the acute pancreatitis. That can be due to long-term alcohol exposure, high ethanol spirits, and it's even higher combined with smoking. These are the other etiologies. There are obstructive pancreatitis other than due to gallstones. There are toxic metabolic pancreatitis other than alcohol. There's the idiopathic pancreatitis where the etiology remains unclear. There are other like autoimmune, infectious, genetic, systemic diseases or iatrogenic. Worth mentioning here is the post-ERCP pancreatitis that makes up to 5% of all pancreatitis and occurs in 5% of every ERCP. To make the diagnosis of acute pancreatitis, you need 2 out of the 3 following criteria. The first is the acute onset of persistent epigastric pain, often with radiation to the back, and the onset of the pain defines the beginning of the pancreatitis. Other possible symptoms are nausea and vomiting with up to 80%, symptoms of intestinal paralysis up to 70%, and tachycardia or vigilance disorders. The second criteria is a 3-fold elevation of lipase or amylase, and it has to be said that the lipase is more specific than the amylase. The serum amylase arises within 6 to 12 hours after the onset of acute pancreatitis and has a shorter half-life than lipase. Serum lipase peaks not until 24 hours after the onset of the pain. The third criteria is typically finding on a radiological imaging that can be a CT scan, an MRI, or an ultrasound. But if you only need 2 out of 3 criteria, that means the presence of the typical pain and the laboratory constellation is sufficient to make the diagnosis and no imaging is needed. It's important to say that the intensity of the pain is neither decisive for the course nor for the inflammation of acute pancreatitis, and the level and course of pancreatitis enzymes have no prognostic value. As I said, now there is no imaging needed for the diagnosis, but nevertheless, abdominal ultrasound is mandatory to determine the etiology of the pancreatitis. With ultrasound, you can assess the common bile duct and the gallbladder, see if there are any gallstones or concrement in the gallbladder, or if the common bile duct is dilated, is there any biliary obstruction or inflammation. You can assess the pancreatic texture, if there's any edema or maybe calcification as a sign for a chronic pancreatitis. You can see abdominal free fluid as a sign of inflammation. If the diagnosis is uncertain, you should consider a CT scan. In the early CT scan, it will not show any necrotic or ischemic areas in the pancreas because it's just too early to detect them. The CT scan is helpful, especially to rule out secondary perforation peritonitis, mesenteric ischemia, and it also shows active hemorrhage or thrombosis associated with acute pancreatitis. Now we got a patient on the ER with a pancreatitis. We would like to predict the severity, but that's very difficult because of the heterogeneity of the disease. There are several predictive scores that have been developed. Some are pancreatitis specific, like these ones. Some are not pancreatitis specific, like the SEER score or the Apache 2 score. The Ranson score is a widely used score, and we often use the Ranson score. But all the scores, they have their advantages and disadvantages. These predictive models, they have a low specificity, and when coupled with the low prevalence of severe acute pancreatitis, the positive predictive value of these measurements are very low. There are some laboratory findings, such as a highly elevated CRP over 150 or a low calcium, that are suspicious for necrosis and therefore for a severe course of the disease. But after all, in summary, there is no gold standard prognostic score at the moment. Now for the classification. There's the Atlanta classification, was published in 1992 with 2 categories, mild and severe pancreatitis. And it got revised in 2012 into 3 categories, like mild, moderate to severe, and severe pancreatitis. The Atlanta classification differentiates between 2 types of pancreatitis. That's the interstitial edematous pancreatitis that makes up to 85% of the cases, with an overall mortality of only 5%. There's a diffuse enlargement of the pancreas due to the edema. And in the CD, you see the parenchyma with homogeneous enhancement and the peripancreatic inflammatory changes like the typical haziness. The second type is the necrotizing pancreatitis. Is only 15% of the cases, but with a much higher mortality of overall 17%. There are typically necrosis of the pancreatic parenchyma, and the natural history of this necrosis is very variable. They can remain solid, they can liquefy, they can remain sterile, or can become infected, can persist or disappear. Now for severity, I already told you there are 3 degrees. The interstitial or the necrosing pancreatitis can be divided into these 3 degrees. There's the mild acute pancreatitis. There's no organ failure and no local systemic complications. There's the moderately severe acute pancreatitis. Is defined as a single organ failure that resolves within 48 hours and or a local or systemic complication without persistent organ failure. And there's the severe acute pancreatitis with a persistent single organ failure over longer than 48 hours or a multiple organ failure. We just take a look at the organ failure. You can divide it into these 3 severity grades. And the organ failure can be either renal failure, respiratory failure, or cardiac failure. And it's defined as a score of 2 or higher in the modified Marshall score. Just want to show you the modified Marshall score. That's an established scoring system for organ failure, and it's very simple to use. A score of 2 or more defines the presence of an organ failure in any system. So if you got a respiratory failure, you have the low oxygenation. If you got a renal failure, it's defined as a serum creatinine over 170. If you got a cardiac failure, it's a systolic blood pressure lower than 90 and is not fluid responsive. If you take a look at the other points, these local systemic complications, you can divide the mild from the moderately severe acute pancreatitis. According to the revised Atlanta classification, a systemic complication is defined as an exacerbation of an underlying comorbidity, such as a congestive heart disease, chronic liver failure, or chronic lung disease. The local complications for the interstitial pancreatitis, it's an acute peripancreatic fluid collection or a pseudocyst, and for the necrotizing pancreatitis, acute necrotic collection or a walled-off necrosis. I now want to talk a little more about these local complications. For the interstitial pancreatitis, as said, is acute peripancreatic fluid collection. That's a homogeneous fluid with no fully definable wall that usually occurs in the first 4 weeks of the disease. Most of these acute fluid collections resolve within 7 to 10 days, only 7% persist. And if they persist, it takes around these 4 weeks to maturate, and they can build out a well-definable wall. It's still homogeneous fluid and are now called a pseudocyst. Here's a picture first for the peripancreatic fluid collection, like this homogeneous fluid around the pancreas. And if they don't resolve and maturate, they build out a well-defined wall that is completely encapsulates the fluid collection. It's still homogeneous, has no non-liquid contents. The collection is usually round or oval, and the fluid collection is typically extrapancreatic. For the necrotizing pancreatitis, there's the acute necrotic collection. That's a heterogeneous collection with no fully definable wall. That is again in the first 4 weeks. If they maturate, they can build out a well-defined wall too, still heterogeneous, and they're called now a walled-off necrosis. That's a picture of the acute necrotic collections with necrosis involving both the pancreas and the peripancreatic tissue. If they maturate during the 4 weeks, they can build out this well-defined wall. Like you see in this picture, this wall completely encapsulates the fluid collection. It's still heterogeneous fluid collection with liquid and non-liquid density, and it can be intrapancreatic and or extrapancreatic. Now for the therapy of the acute pancreatitis, there's the supportive therapy to prevent secondary complications and therefore decrease the mortality. There's a causal treatment, especially for the biliary pancreatitis, and there's the treatment of the complications. I'm going to talk especially about these local complications I just showed you. Supportive therapy has three major cornerstones. Number 1 is the fluid replacement. Number 2 is analgesia. And 3 is the nutrition. During acute pancreatitis, there are inflammatory cytokines that are released, and that leads to vasodilation and increased vascular permeability. That leads to a shift of fluid from the intravascular space into the interstitial space, and hypotension and tachycardia can occur and end in a distributive shock. So the fluid therapy is a long-established cornerstone of initial management is to prevent hypovolemia and organ hypoperfusion. It's important always start with aggressive hydration. It's suggested to take crystallate fluids, normal saline or Ringer's lactate. You can start with an initial bolus from 5 to 10 milliliter per kilogram, and for patients with severe volume depletion that manifests as hypertension, tachycardia, you can raise up to 20 milliliter per kilogram as a bolus over 30 minutes. And then a resuscitation with 2 to 3 milliliter per kilogram per hour for the first 8 to 12 hours. After that, there's a goal-directed therapy for fluid management. And the goals are the vital signs. We want the heart rate under 120 beats per minute, the mean arterial pressure between 65 and 85. Very good indicator of the intravascular volume status is the urine output. That's supposed to be over 1.5 milliliter per kilogram per hour. And the last goal is a reduction in hematocrit with a goal between 35 and 44%. Inotropes, you sometimes have to use it, but only if necessary, because you have to be careful due to the vasoconstriction that can lead to reduced perfusion and more necrosis. Second point is analgesia. The pain is the predominant symptom of acute pancreatitis, and it should be treated promptly. You can start with basic analgesia, but usually you need opioids, and opioids are safe and effective of providing pain control in patients with acute pancreatitis. And usually a PCA, a patient-controlled analgesia, is a good way to help the patient. The third point is nutrition. Patients with mild pancreatitis can often be managed only with hydration, and early oral feeding with the first 24 hours as tolerated with a low-fat diet is recommended. Sometimes you need nutritional support if it's required, and usually often is required in patients with moderately severe pancreatitis due to nausea, vomiting, postprandial pain, and it's almost invariably needed in patients with severe pancreatitis. If you need nutritional support, the nasojejunal tube is preferred to a total parenteral nutrition because there are significant fewer central line infections, fewer sepsis rates, and fewer metabolic complications such as hyperglycemia. A big question always for the pancreatitis is if there are prophylactic antibiotics indicated. But it is a recurrent topic, but most recent recommendations or studies say there's no prophylactic antibiotics because there's no reduction of infection of necrosis. But, and there's another big but, it's up to 20% of all patients that suffer of an extrapancreatic infection, such as bacteremia, pneumonia, or urinary tract infections. And these infections increase the mortality. That's why when an infection is suspected, you should start the antibiotics and the source of the infection is determined later. So don't lose any time when the patient has any signs of infection. Now I want to talk about the causal treatment of biliary pancreatitis. Of course, for alcohol-associated, the abstinence is essential, and drugs associated with acute pancreatitis should be discontinued. But causal treatment for biliary pancreatitis, if there is an obstruction, it's the ERCP. In most patients, the stones pass into the duodenum, but however, if they stay in the tract, they can do obstruction. And there are some indications to do the ERCP. It's when a patient has acute pancreatitis, persistent obstruction, and acute cholangitis. That's the only reason to do an urgent ERCP within the first 24 hours. Because urgent ERCP reduces the severity of the gallstone pancreatitis. The second point is acute pancreatitis with persistent obstruction and no cholangitis. Here, the time of ERCP has no effect on the outcomes. No need for urgent ERCP. It's suggested to do the ERCP within the first 72 hours, but no need to do it in the first 24 hours. A third point is if you got a dilation of the common bile tract and elevated cholestatic parameters, MRCP or endoscopic ultrasound should be performed to detect any stones or sludge in the common bile duct. Important to say that the routine ERCP with acute gallstone pancreatitis is not indicated, only if you have any of those symptoms on this slide. When we have no obstruction or the ERCP is done, the next question is there a cholecystectomy indicated? There's only one right answer. The cholecystectomy should be performed after recovery in all patients with biliary pancreatitis. For the mild pancreatitis, it can be safely done within the 7 days of the recovery and has to be done in the same hospitalization. These are mostly retrospective trials that have shown a benefit for early cholecystectomy. And then in 2015, there was the Pentatrial, a multi-center randomized control trial that compared interval cholecystectomy versus same admission cholecystectomy. They could show a reduced rate of recurrent gallstone-related complications, such as recurrent acute pancreatitis, cholecystitis, or cholangitis. But that was only for the mild pancreatitis. For the moderately severe or the severe, it still counts. It should be performed after recovery. If it's only a moderately severe pancreatitis with a transient organ failure, a single organ failure, it could be done in the same hospitalization. Otherwise, you have to delay it until the active inflammation subsides and fluid collection resolves or stabilizes. That usually takes around 4 to 6 weeks. In the beginning I said there's no need for a CT scan, but sometimes a CT scan is important. If you have a moderate to severe or severe acute pancreatitis, if you have signs of sepsis or a clinical deterioration, the optimal timing for the CT scan is after 72 to 96 hours after onset of the symptoms. And that is important to do it in this time because the complete extent of pancreatic and peripancreatic necrosis, they may only occur and become clear after 72 hours after the onset of the pancreatitis. For patients with severe acute pancreatitis, there should be done a follow-up CT scan after 7 to 10 days. Afterwards, if the patient shows improving clinical status, additional follow-up scans during the hospitalization are recommended only if the patient's clinical status deteriorates or if he fails to show any improvement. Because it's important to say here that the resolution of the CT manifestations of pancreatic inflammation, it always lags behind the improving of the clinical status of the patient. We made this CT scan, so what can we see in these scans? That's the picture we saw before, this acute necrotic collection. But sometimes, if the patient doesn't improve, we have this picture with the presence of gas within the necrosis. That's a clear sign of infected necrosis. That's a dreaded complication, and approximately 1/3 of all patients with necrosis develop infected necrosis. The majority of the infections are gut-derived organisms such as E. coli, Pseudomonas, or Enterococcus. Antibiotic therapy should be initiated if you have this picture, if you have such a huge amount of gas in the necrosis. The most recommended antibiotics are meropenem or imipenem. And if it's unclear, if the picture isn't that clear, you could perform a fine needle aspiration to prove infected necrosis. So now we got this infected necrosis. Now the time to take the patient to the operating theater. No, it's not. That's very important because in the early phase of the pancreatitis, the illness is characterized by an acute systemic inflammation response syndrome. The optimal time for surgery is approximately 4 weeks after onset of the pancreatitis. The inflammation has decreased, the process has organized, and the delineation of life from that tissue has completed. At this point, you have this, what we saw before, this so-called walled-off necrosis. So you only do an operation or an intervention for infected necrosis in the first few weeks if there's no improvement under conservative therapy. Otherwise, you try to delay the intervention or necrosectomy by continuing antibiotics and conservative treatment. There's another indication to do intervention. These are the symptomatic sterile necrosis. It's a typically large volume of retroperitoneal necrosis. If you have an ongoing gastric outlet, interstitial or biliary obstruction due to the mass effect of these necrosis after 4 weeks, you should perform an intervention. Or if you have persistent symptoms such as abdominal pain, nausea, vomiting, or weight loss after more than 8 weeks, you should perform an intervention too. I now want to talk about the different interventions. That's a study that was published in 2010 in the New England Journal of Medicine, the so-called Pentatrial. The hypothesis of this trial was that the outcome may be improved by a minimally invasive step-up approach compared to open necrosectomy. The primary endpoints in this study were major complications or death. The major complications are multiple organ failure, multiple systemic complications, perforation of a visceral organ, a hemorrhage, or an intracutaneous fistula. The open necrosectomy consisted of a laparotomy through the bilateral subcostal incision, blunt removal of the necrosis, and insertion of 2 large drains, and then the abdomen was closed. Here in this picture, you see the step-up approach. The first step was a percutaneous drainage preferred through the left retroperitoneum. And if there was no clinical improvement after 72 hours and the position of the drain was inadequate, a second drainage was placed. If that wasn't possible or the patient didn't improve in the next 72 hours, was a second step. The video-assisted retroperitoneal debridement was performed. That's on the left lower corner, the number D shows the ward procedure. And the outcome of this study was to show that the surgical step-up approach was better than an open necrosectomy. There were significant fewer multiple organ failures, 12% compared to 43% in the open necrosectomy. For death, there was no improvement for the surgical step-up approach. But important is the kind of 35% that only need a percutaneous drain and no surgical intervention after all. Lower there is the incisional hernia. There's a secondary endpoint that was significantly lower for the surgical step-up approach. In 2018, there was another study, another Dutch study, published in the Lancet, a so-called tension trial, and they tried to compare the endoscopic versus the surgical step-up approach. The surgical step approach here consists of the exact same procedure as we saw in the study before, percutaneous catheter drainage followed, if necessary, by a video-assisted retroperitoneal debridement. The endoscopic approach consisted of an endoscopic ultrasound-guided transluminal drainage, followed, if necessary, by an endoscopic necrosectomy. The primary endpoints here were the same: major complications or death. Right here you see the endoscopical step-up approach. It's an ultrasound-guided transluminal drainage replacement of 2 7 French pigtail stents and a nasocystic catheter. If the drainage alone didn't lead to a considerable clinical improvement, the endoscopic transluminal necrosectomy was performed, like on the left side here. The outcome of this study showed that the endoscopic step-up approach is not superior to a surgical step-up approach. No fewer deaths and no fewer major complications in both groups. But what it showed is that the rate of pancreatic fistulas and the length of hospital stay were lower in the endoscopic group. All right, here that's a little overview of what I just talked. It's beyond the early phase of the acute pancreatitis. If there's no clinical improvement, you repeat the CT scan. If you see there any infected necrosis, it's important to check if they are already walled off. If they're not, you try to go on with the conservative treatment with antibiotics and supportive care. If they are walled off, you can do an endoscopic or percutaneous drainage, so you start the step-up approach. And then if there's no further clinical improvement after 72 hours, you do another CT scan. If the collection is not drained adequately, you can do another drainage and see if the patient gets better. If not, you just start over again, do the CT scan and see if the drainage is adequate. If it is, and there's still no improvement, you can do either the surgical step approach or the endoscopical step-up approach. Important is what stands on the bottom of the page is the maximal supportive care in ICU in case of organ failure. That's always important for this severe pancreatitis. They need to be on the intensive care unit of a big center. And on the left bottom is this other indication for intervention, a mechanical obstruction or failure to thrive and walled-off necrosis, even if there is no infection. To end, I just want to show you one short case. It's a case of a 60-year-old patient who was assigned to our institution after failing to improve in another hospital, and in the CT scan he showed typical signs of infected acute necrosis. Because he didn't improve, we started the step-up approach, did an interventional drain replacement to begin with. After that, he still did not improve. We did the CT scan. You see on the left side, there was an adequate drainage of this collection. What means we had to step up. We did the video-assisted retroperitoneoscopic debridement. That's an operative picture you see here. And after that, it should be over, because that's what I talked before, but it's important to say sometimes it's not over with this step-up approach. Not always is that enough. So in this patient, we had to do a laparotomy with necrosectomy, splenectomy, and cholecystectomy, because he still did not improve after the intervention. And these are the interoperative pictures with the cholecystectomy, and these are the necrosis of the pancreas, with 60 grams of necrosis that were taken out. Unfortunately, in this patient, 3 days later on the ICU, he died anyway after all the effort. Now for my conclusions, there's good evidence that there are no prophylactic antibiotics needed. The biliary pancreatitis demands a same-day admission cholecystectomy for the mild forms. And for infected necrosis, the step-up approach seems to be superior to open necrosectomy in regards to major complications. And that's all. Thank you very much for your attention.
Thank you very much. Took a little bit long time, but that's a complex disease. This is a frequent disease. Despite these 2 randomized controlled trials, I think there's a lot of questions. Number one, for me, this is a clear surgical disease that most of the time need to be treated conservatively. And there is strong data, if we looked at experience or centers who are used to this disease, including intensive care, is the single most important factor for good outcome. I disagree with a number of the conclusions here that you are saying, disagree in terms of what we are doing here. I think it's important to go back. There has been stat in the late 80s when a German surgeon, Professor Beger from Germany, came for the first time to identify infection in the necrosis, and for more than a decade it was puncture of the necrosis, if infected surgery, if not infected no surgery, which was a simple way to decide. Today is a bit different in terms of what we're doing for this disease. So I want just to say on the prophylactic antibiotics, this is not what we are doing, and the data is not so strong. What is clear, and that was not the case 10 years ago, but now with a large study from the Netherlands and others, you do not give antibiotics for predicted severity. There's a difference between predicted, what you predict with all the score you mentioned, and the real severe pancreatitis or necrotizing pancreatitis that you have on CT scan. So our policy and many other centers, if it's predicted, we don't go immediately with antibiotic, which today is limited to meropenem and imipenem. That's what we give for these patients. But if there are necrosis, then we give prophylactic antibiotics. And the data is not completely clear, but most centers will go with prophylactic antibiotic if there is necrosis in the pancreas, but not if it's only predicted in some way. So that's another thing. Now the stepwise and all this data, it's highly controversial. This is a very small number. This is from one country. This is from a group of very aggressive endoscopists. I'm nothing against them. I know them personally pretty well. This is not reproducible in many centers. We have showing one case we cannot conduct at the end, that it can be a disaster, and this is only in very specific situation that you can go. So this is only in specific situation when we have some localized necrosis or specific indication. Otherwise, this is a conservative management until the patient needs surgery, as we have shown. So he crashed, sepsis. We do that as late as possible. That was the evolution over the years. But we are not going transgastric, etc. I mean, in this center, and there's few centers, but most do not. We don't have, for me, the definitive answer. And I don't believe, we're still in the belief that this is the way to go in necrotizing pancreatitis. So what we know today is that, and that's well established, it's a necrosectomy, close the abdomen, repeat it, and not this open surgery that we have done in the past. We speak that we're open abdomen, lavage, keep open. This is a bit different. So we're not here going on the necrosectomy, transgastric or laparoscopic, etc. We've done a few. Maybe we don't have the experience, but that has not been convincing at all on our side. So there are many, many topics. I mean, for time we can go. It's a very complex disease. I think it needs to be treated in a surgical unit, of course, with the endoscopist and gastroenterology. This is an issue in many places because you have centers wherever they go in the same hospital, they have a complete different treatment, which I think it should not be the case. There should be, at least at the level of a hospital, a consensus how to address this patient. And probably the most important one is the intensive care unit, because that's what you show when they go to sepsis. It's a septic disease that needs to be treated, and irrespective of that mortality, when you say 5% in this Atlanta for edematous basically 0%. If they say edema, it's very low mortality, while in the necrotizing, the one you operate, the mortality is certainly 50, 60 or even more when you have multi-organ failure in these patients. I don't know if there is comment, because I don't want to redo the conference, but I want to clarify that. Any questions? No? Okay, good. Thank you.